So, ma'am, we are now going YouTube live, and 3, 2, 1, we are now live.
Good evening, everyone. My dear esteemed faculty and my dear delegates who all have logged in for this Endolit first webinar, on which is on the 1st of every month, which we are doing it in the evening from 7 to 9. The link and the YouTube link both remains the same. And this time, right now, we are doing this webinar along with collaboration with the Endocrine Committee, along with Public Awareness Committee and Dr. Kalyan, Young Talent Promotion Committee, Dr. Niharika. We 3 committees who are under Dr. Basa Mukherjee as the Vice President, we are doing it all together. And for this, I bring you greetings from President Foxy, Dr. Shanta Kumari, and Secretary General of Foxy, Dr. Madhuri Patel, ma'am, Dr. Basa Mukherjee, who is the Vice President and the key person for us to getting all the 3 committees together. And the brainchild has been working along with us with the Endocrine Committee was Dr. Jaideep Tang, who's the convener, along with the 3 committees, that is me, Dr. Kalyan, and Dr. Niharika. And we have got co-conveners, Dr. Priyankur, Dr. Chamila, Ayavu, Dr. Nagendra, Dr. Chandrika, and Dr. Meenu Handa. All of us have been brainstorming and working at length. And for today, we will have good sessions and pure academics to we bring to all of you. And let's take blessings from our from the President Foxy, Dr. Shanta Kumari, madam. Just a minute.
Dear friends, Foxians, and women of my country, I'm Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Foxy, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti, as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
And I'm so happy to be here with you. It's only on video. Beautiful experience, and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. Foxy for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti, to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for All Always and Dhira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman. Swasth Mahila. Violence against women. I think it's a silent pandemic, and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy, and also especially support her campaign, Dhira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the president of Foxy, declare my commitment towards women's health and safety.
Moving on ahead. Moving on ahead, I would like Dr. Kalyan to say a few words and start the session, please, before we hand it over to Priyanka.
Thank you, Dr. Rakhi ma'am. And with the blessings of all Foxy office bearer, we are with our second session of Endolit, which is a brainchild of Dr. Rakhi Singh, Dr. Jaideep Tank, and Dr. Basam Mukherjee. It is her greatness that she has involved all other committees. So this is my turn of having a topic which is very close to my heart. As everybody knows, we are running a mission called Save the Uterus or Preserve the Uterus. So in this, we have taken a lot of efforts on treatment of AUB and options. So we have all stalwarts today, starting from a young lecturer from Medical College at Latur, Ravindra, and then we have expertise like Dr. Sai Lakshmi, who has a lot of good work on Marina property in her UK practice of around 15 years. Then we have Dr. Basam Mukherjee, sir, who is going to talk on AUB and adolescent, which is a topic which needs a real boosting these days because the young girls are having this problem because of increase in weight and all other problems. We have Dr. Parikshit Tank, who is the treasurer of Foxy, who is going to talk on suppression of menstruation. And we have a panel full packed with Dr. Jayam Kannan ma'am, gynec challenges in girls with disabilities. I wish great success to this conference and thank you all faculties and attendees for attending this session. Thank you and over to Dr. Priyanku. Priyanku.
Now we hand it over to the session to the coordinator for today, that is Dr. Priyankur. He is the National Coordinator for Public Awareness Committee of Dr. Kalyan and the East Zone Coordinator for my committee, and has been definitely a person who's been working very hard all through. And yesterday we came to know that he has been elected as Vice President for Watong from India. Congratulations to Priyankur, and handing over the session to you, Priyankur, please.
Thank you so much, Rakhi ma'am, and thank you so much, Dr. Kalyan, for involving me in this program and giving me this opportunity. And thank you, Rakhi ma'am, for the wishes. So we start this wonderful Endolit program today, the session series 2 that we have today. So this is a program, as you can see on the program, the schedule itself, that it's mainly academics that we'll discuss and not much of time that is spent otherwise. So straight away diving into the academics, I would first of all like to invite our first speaker, Dr. Ravindra Mahadev. Can I have the CV, please?
Sure.
Sir is going to talk to us about a critical analysis of an article from a journal BJOG from 2009, and is going to talk to us about the levonorgestrel intrauterine system Marina for the treatment of menstrual problems in adolescents with medical disorders or physical or learning disabilities. So Dr. Ravindra is the assistant professor at the JJ Group of Hospital, Urban Health Center. He's a senior registrar at the Nausarji Wadia Maternity Hospital in Mumbai. He's a specialist medical officer at the Central Hospital in Ulhasnagar. So I now hand over this platform to Dr. Ravindra to kindly take us through this interesting article.
Thank you, Dr. Pran Kumar. Now we will directly start. Good evening, everyone. So today we are going to discuss the article from BJOG, the levonorgestrel intrauterine system for the treatment of menstrual problems in adolescents with medical disorders or physical or learning disabilities. From the abstract, the menstrual problem is common in adolescents. Management is problematic in adolescents with disability. It has legal and ethical issues. Adolescents with disability tolerate poorly. So LNG-IVS is a good treatment option for them. LNG-IVS provides significant therapeutic benefit for 12 of 14 participants in this study. Majority participants continued for 5 years duration. The rate of expulsion, bleeding, and amenorrhea in adolescents is similar to the older woman, where contraception is primary indication. Into the introduction, adolescents with severe physical or learning disabilities have more challenges in dealing with menstrual problems. It causes significant disruption of their day-to-day life. Caregivers fear about difficulties with hygiene and their vulnerability to exploitation and pregnancy. Problem with management of behavior at the time of menstruation are common. Families often request hysterectomy or permanent sterilization for the same. Nowadays, we see 15% of the adolescents seek medical help at least once for period problem. But menstrual irregularity reported in 55 to 82% of adolescents in first 2 years post-menarche, and the same decreases to 20% around 4 to 5 years. So we can see it's most of the times physiological due to, and it suggests regular ovulatory cycles may take several years to establish after menarche because of immaturity of the hypothalamo-pituitary ovarian axis. Main cause is lack of luteal phase progesterone, which leads to unstable endometrium, leading to very prolonged bleeding. And the pathological causes, hyperandrogenetic states like polycystic ovarian syndrome, hypothalamic dysfunction due to anorexia or excessive exercise. Endocrinology includes thyroid disorder and medications like anticonvulsants and neuroleptics. Anticonvulsants by increasing sex hormone binding globulins and decreasing sex hormones, and neuroleptics by causing hyperprolactinemia. Trisomy 21 is another cause which can lead to hypothyroidism and can cause menstrual irregularities. From the material and methods for the study period is 1998 to 2008, is 10 years. Age group is 11 to 21 years. And prerequisites is failed other medical treatment like NSAIDs, antifibrinolytics like tranexamic acid, combined oral contraceptive pills. COCs were contracted in 7 cases for immobility, liver dysfunction, obesity with diabetes, and hypertension. And remaining 7 cases among the participants tried COCs. High-dose progesterones like norethistone 15 to 45 milligram divide doses or injection DMPA, which has difficult acceptance. Regarding consent, many adolescents were unable to give consent. For under 16 years, parents' consent were taken, and for 16 years and above, but not competent to give consent, treatment given on the basis of best interest. Exclusion criteria was when family disagrees with treatment with LNG-IVS and those willing for hysterectomy only. Admission required for 13 out of the 14 participants for short GA for LNG-IVS insertion. One participant, 15-year-old with hemiplegia, didn't require admission as she was competent and sexually active. Pelvic scan was performed before putting LNG-IVS to ensure the uterus. And menstrual problems are dysmenorrhea, polymenorrhea, and menorrhagia. We can see from the chart summary of the cases. Out of 14 cases, out of 14 participants, one was dissatisfied. LNG-IVS was removed on request after 7 months for pain. Laparoscopy was performed, which was within normal limits. Other medical treatment tried but failed. One participant had expelled IVS after 2 years. 2 participants required long-term progesterone with intrauterine system, and 3 were very successfully managed. 1 was lost to follow, and 2 participants, number 8 and 13, were family related and had some same neuromuscular disorder. Number 8 was competent, but number 13 was severely disabled and incompetent. Both had significant improvement. One participant number 4, removal requested after 4 years for getting pregnant. We can go to the chart and summary of the cases. Same thing. Among the discussion, menstrual distress has negative impact on behavior of adolescents. Reluctance among clinicians was observed to use LNG IUS in adolescents. Both WHO and UK medical eligibility criteria for contraception mention LNG IUS as category 2 for less than 20 years and category 1 for more than 20 years. But it looks illogical because of higher teenage pregnancy rate was observed and adolescents have significantly better compliance for LNG IUS. Among NICE guidelines, LNG IUS is not contraindicated in nulliparous women for any age. LNG IUS reduces menstrual loss by 85% within 3 months. Cochrane 2005 meta-analysis shows LNG IUS versus oral cyclical northeastern or balloon ablation. In that, it has shown LNG IUS significantly more effective at reducing blood loss. From US and Canada, data is less, and that was recently licensed at the time of the study. They were using Depo-Provera, which was most commonly prescribed and accepted method for menstrual suppression, used in teenage with disability in Canada. But Depo-Provera linked with reduced bone density. LNG IUS has added therapeutic benefit for endometriosis also. LNG IUS has a long lifespan of 5 years, so no need for hormone dosage revision and frequent follow-up visits. Among New Zealand, one study shows encouraging results in 179 adolescents 11 to 19 years indicated for menstrual problem and contraception. 85% continuous rate was observed after 1 year. In Australia, 22 participants were less than 20 years in a study. Among those, 16 shown symptom resolution, 1 was failed, 2 expelled, and 2 were removed. Among practical consideration, we can see LNG IUS require minimum uterine activity of 5 to 6 centimeter size. NSH is required short GA, ultrasound for pre-placement to ensure uterus, and for a small cavity, newer devices are more appropriate. Disadvantages about this is it requires general anesthesia, additional medical management needed for initial months to control of prolonged bleeding. In some cases, acne and headache was observed. In conclusion, we can see adolescents with physical and learning disabilities have high frequency of pain, heavy and prolonged bleeding, and hygiene problems. LNG IUS provides good therapeutic benefit, improved quality of life. Additional contraception benefit is added bonus. There was no adverse event in any case in the study. 1 was therapeutic failure, 1 was expulsion, and 12 were significant benefit. Thank you so much.
Thank you,
Thank
Dr.
you so much.
Thank you, madam, for giving me the opportunity. Thank you, Dr. Kalyan sir, for giving me the opportunity.
Thank you. The basic crux of this whole Endolit first webinar series was to combine the journal article and then also have a discussion on the journal writing, how it is, what importance it gives, and thereafter the lectures related to the topic also. Thank you.
Thank you,
It was lovely hearing you, Ravindra.
So thank you, Dr. Ravindra, for that wonderful analysis of the article, I would say, which is like the initial stepping stone to the wonderful discussion that I'm sure we're going to have in the session hence forward. So thank you so much for doing it for us. So
Thank you
now
so
we
much,
move
sir.
on to the now we move on to the second session, and I would like to introduce the speaker for this session. So can I have the CV, please, Nikita? I would like to welcome Dr. Sai Lakshmi to our platform. Ma'am is going to talk to us on LNG IUS in AUB. She has graduated from the Osmania Medical College, and after that she has spent 18 years in the United Kingdom. She has done a lot of work in LNG IUS when she was there, and she is currently working in the Apollo Cancer Hospital in Hyderabad as a senior consultant in gynae oncology. Ma'am happens to be the only fully UK trained gynae oncologist currently working in India. It's a privilege that you have given your valuable time to us, ma'am, and I'm sure all our delegates are going to benefit immensely from it. So I hand over this platform now to Dr. Sai Lakshmi to kindly start her presentation.
Thank you so much. That's really a very kind introduction.
Ma'am, I'm sharing.
Can we run our presentation?
No, you have to ask now.
Yeah. Can you see the and yellow slide?
Yes, we can see and hear you.
The very feminine looking slide. Well, I don't want to waste any time because all the topics look so interesting. I'm so keen to listen to the rest of the lecture. So I'll do mine really quick, and I want to stick to 15 minutes. And the topic given to me is LNG, IUS, and AUB. And though I'm an oncologist and see a lot of cancer patients, I do see a lot of benign gynecology too. And LNG, IUS is something I use on a daily basis. So this is something, why am I not moving? One sec. Yeah. Sorry.
Dr. Sai, Nikita is running your slides. So you have to just go next.
Yeah, that's great, Nikita. Thank you. Saved me from such an embarrassment. Well, as we all know, I don't want to define AUB all over again. We all know what AUB is. Frequency outside the normal range, the duration of bleeding outside the normal range, and blood loss outside the normal range. And what I want to actually press on now here is, when we talk about AUB, there is always acute and there is always chronic. And there is always acute on chronic. There are women with chronic AUB who come to you when it becomes acute. So we need to know when to do what. When do you want to do acute management, and when do you go on to treating the chronic AUB? And most of the times, LNG IUS is useful for the management of chronic AUB. Next, please. I'm going to follow the Foxy Pam Cohen formulation because that's what we are following. When it comes to AUB and polyps, what's the role of LNG IUS? Polypectomy is the thing to do. But then there is a reason why these women develop polyps. So once you have done your polypectomy, majority of the times, none of us do blind polypectomies anymore. It's hysterectomy, hysteroscopy, polypectomy, and insert the LNG IUS at the time of polypectomy. And obviously, if there is no malignancy in the polyp, then you have taken the precaution to avoid future polyps. So LNG IUS is the second line management for polyps after you have done a polypectomy. Next, please. Obviously, in the Pan-Cohen terminology, it's adenomyosis. According to me and according to the textbooks and according to so many people, there is one indication for benign condition, and that's adenomyosis. It is considered to be the heart attack of the uterus. The pain with adenomyosis is so bad that if a woman who's really suffering with adenomyosis comes to me and she's finished her family, I do not hesitate to do a hysterectomy because it's one condition where nothing actually really works very well. But if the woman wants to seek fertility, if the woman doesn't want a hysterectomy or she's not in the right age group, you want to try something, then you can definitely try LNG IUS, which does help, which is being proven in RCTs that it does help with adenomyosis. So the first and the best treatment option is hysterectomy. There are few case series of adenomyomectomy. Personally, I've never done one, but then LNG IUS does have a place, especially when there is large adenomyosis and the woman doesn't want a hysterectomy or she wants to be fertile. CA125s have gone up. LNG IUS has been shown to control the pain and also help these women become fertile by reducing their CA125 levels and by reducing the peritoneal inflammation. Moving on to leiomyomatosis. I myself personally have inserted hundreds of myrinas in women with leiomyomas, especially when it is subserosal and intramural. I don't even think twice. I don't hesitate. The only time when I don't prefer or when I think the myrina might not work is when there is a submucosal fibroid. Of course, not just LNG IUS, there are many other non-hysterectomy options for leiomyomatosis, being GnRH analogs, oral progesterones, or mefenamic and tranexamic acid taken periodically at the time of menstruation. Moving on to malignancy, which is my favorite topic and which is where next slide please, where I use most of the LNG IUS. If a woman with endometrial hyperplasia and no atypia comes, LNG IUS is my first line of management. Those of you who are still used to the simple and complex hyperplasia, it's time to move on. We have a very clear guideline which says hyperplasia is either with atypia or no atypia, no more simple and complex and anything in between. So endometrial hyperplasia, no atypia, endometrial hyperplasia with atypia, and then the endometrial hyperplasia, which has actually turned into an endometrioid carcinoma. Next slide, please. According to WHO 2014, obviously, like mentioned, there is atypia or no atypia. Next slide, please. We're talking about hyperplasia with no atypia. Very few percent of these women actually turn into malignancy, less than 3%. And therefore, the best treatment option is progesterones because there's such a low risk of malignancy. Why would you want to do a hysterectomy for hyperplasia with no atypia? And then, next slide, please. When do you stop the progesterones? Well enough, you put them on progesterone. When do you stop it? These are the women with hyperplasia. Why did hyperplasia happen to them? Is that because they are obese? Is that because they are diabetic? Is that because they have risk factors for obesity and diabetes? So it's hard to know when to stop progesterones. So you could give them Proviro or Megace between 20 and 40 milligrams per day, but how long? That is my point. When you don't know when to stop it, it's better to insert an LNG IUS because with that, there is no question about when to stop it. As long as the woman doesn't want to get fertile, you can keep it in for 5 long years and the hyperplasia is under control. That is a benefit of LNG IUS when it is hyperplasia with no atypia. Next slide, please. Therefore, LNG IUS happens to be the first-line treatment option as per the Cochrane database RCT conclusion, oral progesterone being the second-line treatment option. Next, please. We'll now talk about hyperplasia with atypia. What percent of these women have a progression to malignancy? It is 50%. And therefore, the best treatment option happens to be the hysterectomy. Great. I mean, that is very clear and very straightforward. But what if, like me, you happen to see so many of these women with hyperplasia with atypia referred to me from the fertility clinics, and they want to conceive? This is an increasing scenario in so many women with PCOS. You know, they have infertility, they go to the fertility specialist, they have a hysteroscopy, and then there's hyperplasia with atypia, and they end up with me between the ages of 25 and 35 with hyperplasia with atypia, and they are yet to conceive. And this is where I really feel like crying because ideally I should be offering them hysterectomy. What if it is actually a grade 1 endometrioid carcinoma of the endometrium? Please go back a slide. And this is where you really don't know what to do. The woman wants to conceive, you can't remove her uterus. And this is where LNG IUS has a very big role to play. Next, please. So if these women want to keep their uterus, they want to get pregnant and they have atypia, they have early stage endometrioid carcinoma confirmed on the biopsy and confirmed on an MRI scan that you're not dealing with anything more than stage 1A, you can treat them. This is proven on RCTs, this is proven on Green Top guidelines, Australian college and American college. All the colleges tell you that, yes, you can treat them. You can treat them with Proviro or Megace or LNG IUS. Next, please. So the doses you give are very, very high, extremely high doses of MPA or Megace or the standard LNG IUS, which delivers a small quantity of LNG into the uterus for over 5 years. It takes 3 to 12 months for these women to respond to your progesterones, either the oral progesterone or the intrauterine progesterone. But the treatment minimum duration is 12 months. Though the response can be seen within 3 months or 6 months, you have to treat them for 1 year before you give them the green signal to get pregnant. And you have to have 2 negative biopsies 3 months apart. So it's not that if your 3rd month and 6th month biopsies are negative, you allow them to get pregnant. You still treat them for 1 year. But even when you're treating them for 1 year, you have to have 2 consecutive negative biopsies 3 months apart. Next, please. So now you have this lady with an early stage endometrioid cancer, or you have atypia and you want to treat them. And which is your treatment of choice? You know, I see minimum 5-6 such patients on a weekly basis in my clinic. And therefore I get to make this choice plenty of times. And almost always I choose the LNG IUS. I'll tell you why in a moment. Next, please. And according to the Royal College protocol, the protocol is do a DNC, confirm that it is hyperplasia with atypia or it is stage 1A, grade 1 endometrioid type 1 type cancer of the uterus. And then at the time of DNC, insert the Mirena coil. And as long as your biopsy is not something worse than what you thought it was, you can continue with the LNG IUS. but every 3 months, do a pipelle biopsy in the clinic with a Mirena in situ. Some people say if the LNG-IUS is in the uterus, then you get a false negative report. That's not the point. That is your treatment. And you want to know what the biopsy is when you're treating this woman. So you let the LNG-IUS be in the uterus, and in the clinic, you do biopsies from all the quadrants of the uterus, which is what I do on a 3-monthly basis. Most of these women are melliferous, and it's not so easy doing a biopsy in the clinic. So I pre-treat them 4 hours before the biopsy in the clinic. I give them mefenamic acid, Dolo 650, and 800 micrograms of misoprostol. And in spite of giving misoprostol, I've never had any expulsions of the Mirena so far. And I keep doing this on a 3-monthly basis. By this time, the patient would have had frozen oocytes or frozen embryos. If they don't die, I make them have frozen oocytes or frozen embryos before I start treatment with LNG-IUS, because once the treatment is done, you don't want them to have estrogen stimulation. You want them to straight go for the IVF pregnancy. And after 1 year of treatment, we advise them to get pregnant, and after conception and delivery, we advise them to have a hysterectomy, and we have had quite a good success rate with fertility. But say you're dealing with a woman who can't have hysterectomy, but who actually doesn't want to get pregnant with hyperplasia or stage 1A grade 1 endometrioid carcinoma of the endometrium. So she's got a really high cardiac risk, or she's 150 kilos and the anesthetist doesn't want to give her anesthesia. Then in such a case, you can keep this for longer. You can keep this for 5 years and keep doing a biopsy every 6 months. So personally, I've almost never faced this situation. I only advise LNG-IUS for women with atypia or carcinoma only if they want to get pregnant, because these days, robotically or one way or the other, even with very high morbid patients, you can do a hysterectomy and get away. Next, please. So like I said, when you start to think about what to use, oral progesterones or LNG-IUS, Cochrane made life easy for us. It's clearly said that from cancer controlling point of view, LNG-IUS works better because the treatment is very localized. And from a side effect point of view, again, LNG-IUS works better. And now the third thing in the equation is the cost. In addition to proving that it works better for the condition with less side effects, LNG-IUS is extremely cost effective. Next slide, please. And if you treated somebody for a year with MPA, it costs around 75,000 rupees for the entire year versus around 60,000 rupees for MIGS. While the same treatment, if instead you use the Mirena, obviously we know that Mirena costs 3,600. I mean, that is a discounted price in India. And whatever you would charge for insertion, 2,000, 3,000, 4,000. But you can see it is 1/10 the price of oral progesterone with hardly any systemic side effects. Give somebody 200 to 400 MPA per day or 160 milligrams of MIGS, and they're going to have significant breast tenderness, headache, and bloatedness. And ask someone to take this for a year, compliance is going to be an issue. Next slide, please. So in addition to everything else, cost is a big thing. And we get LNG-IUS in India for a very, very low price. And that's basically because it's been heavily subsidized by the company based on Indian government rules. Next, please. So for endometrial hyperplasia, no atypia, undoubtedly the first line treatment option is LNG-IUS. Next slide, please. For endometrial hyperplasia with atypia, the first line treatment option happens to be a hysterectomy, undoubtedly. The second line is LNG-IUS when you can't do that hysterectomy. And then the third line is high dose oral progesterones when you can't insert LNG-IUS for whatever reasons, though I can't really think of a reason. Next, please. When it comes to early stage carcinoma of the type 1 carcinoma of the uterus, undoubtedly, again, underlying hysterectomy is a first line treatment option, unless a woman is desperately keen to get pregnant, when LNG-IUS is your second line. And then the third line would be the extremely high doses of MPA or MIGS. Next slide, please. Moving on to our AUB classification, coagulopathy. According to the Cochrane database, again, the best treatment option when young girls come to you with coagulopathy and AUB is COCP. But for whatever reason, if you can't give them estrogen, then like the previous speaker so beautifully told us that even in adolescence, we could use LNG-IUS. LNG-IUS happens to be the second best line just because these adolescents will keep bleeding month after month after month. It is the inherited coagulopathy. Then LNG works for 5 years and therefore it becomes a very good treatment option. And you're worried about them bleeding the day you insert, give them tranexamic acid for a day or two. Next, please. And ovulatory dysfunction. This again, Dr. Kalyan's favorite topic. This actually many times is mentioned. When we see people with PCOD, we get carried away by treating them with hormones, by doing so many things to them, forgetting that it's actually a lifestyle disease. And emphasizing lifestyle changes still happens to be your first line management with any obese girl who comes to you with hormone dysfunction. We have to emphasize to them that whatever we're giving them, modifying their lifestyle actually happens to be the best line of treatment option. And therefore, lifestyle changes come first, followed by any of the choices. COCP works as good as oral progesterones versus LNG-IUS. The choice is yours. Next, please. And endometrial disorders, this is one of the classifications. Disordered proliferation, I see this a lot in histology specimens, and disordered proliferation is the first thing that goes wrong before that turns into hyperplasia. And again, if somebody has disordered proliferation, it means they have a hormone imbalance affecting their endometrial proliferation. And if the woman has completed family or wants a long gap between children, or waiting to get pregnant but not yet ready there, you can insert LNG-IUS. Endometritis, obviously, you don't want to put anything into the uterus. You want to give antibiotics. Rare conditions, AV malformations, embolization is a recommended treatment. I don't think there's any role for LNG-IUS there. Next, please. I'm nearly finishing now. Next, please. Iatrogenic tamoxifen. If there is one take-home message, it's so tempting to put LNG-IUS in someone who is on tamoxifen, knowing her endometrium is going to get thick. But one warning bell, if that breast cancer for which you're giving tamoxifen is progesterone receptor positive, we still don't know. There are trials which said that maybe it is safe to insert LNG-IUS, but we don't know. The last thing you want to do is increase the risk of recurrence of breast cancer in a woman who is taking tamoxifen by inserting LNG-IUS. So I personally don't recommend it. And none of the trials so far, none of the studies so far said you can or you can't. I think there is one RCT in progress, which will come out sometime in 2 years, which will tell us if it's okay to use LNG-IUS in this situation. Next, please. Until then, just be careful and better don't. Next slide, please. And then the last couple of slides, why LNG-IUS? Why so much talk about it? One, because AUB is so common. 10 to 35% of women have AUB. With LNG-IUS, because it's low cost in India with a very high patient satisfaction rate, it seems to be the first and best option, and it's extremely cost effective and it's reversible. When this poor lady gets over the AUB symptoms and wants to get pregnant, you can take it out and there you go, she can get pregnant again. Next slide, please. And fertility sparing, obviously an important issue these days when women are getting fertile very, very late. I see many 35-year-olds just about thinking to fall pregnant. So it seems to be that one-stop answer to AUB, and it's equivalent. Many papers have quoted LNG-IUS to be a medical hysterectomy. And therefore, I think this is one treatment option which we should all have first on the list in the management of AUB. My favorite still happens to be COCP and mefenamic acid and tranexamic acid. But when I see a woman with chronic AUB, I always think of LNG-IUS as the first line. Next slide, please. And what do you do? Of course, there are going to be side effects, and side effects vary from person to person because LNG binds to SHBG in our plasma, and all our SHBG levels vary. And that is why side effects vary from person to person. One last slide on what do you do? If someone has high systemic side effects with LNG, remember, they are the people with high SHBG levels, and they will have much higher side effects with COCP or oral progesterones. So if someone gets breast pain or headache with Mirena, they're going to get it even with your other treatment options. So don't think I'll take Mirena and give her COCP and she'll be absolutely fine. She won't. She'll have the same side effects because logically that's what it is. It's how much hormone binds to the SHBG. The last slide, please. And what do you do if it is spotting for the first few weeks? I usually give them a small dose of oral progesterone. But if someone has been amenorrheic for a very long time and then they start to spot, I usually give them 2 packets of COCP if they are less than 40 years of age, and it usually does magic. The spotting stops. Or if it's an older woman, then ulipristal twice weekly for 2 to 3 weeks usually does the trick. So I don't just take the Mirena out. I give them COCP or ulipristal, and that seems to do the trick. I guess that's my last slide, and can't thank Dr. Kalyan enough for this opportunity. I'm so looking forward to the rest of the talks, and I really liked the first talk too. Thanks so much. Thank you all.
Thank you, Dr. Sai, for such a nice and innovative talk about LNG IUS. I know you are a master of using LNG since last 20 years now. Only one question comes to my mind. Nowadays, those girls with disabilities are undergoing hysterectomy. So can you just enumerate the use of LNG in these girls? Girls.
I mean, the last thing you want to do to these girls who are struggling to manage themselves physically, mentally, emotionally because of learning disabilities is to do a major surgery. Because even doing a major surgery and getting them to recover from it, understanding why they are undergoing the surgery is in itself a difficult thing. And in the UK, we did see a lot of girls with Down syndrome who did not menstruate, but then we saw some girls with paraplegia and other learning disabilities, especially girls with cerebral palsy, where they had no chromosomal abnormalities and they would bleed. And in that group, we would give them a short general anesthesia and insert Mirena, and it worked beautifully. Because they are not people with AUB, they never had the side effect of spotting or anything. They just become amenorrheic within 3 to 6 months. And the parents were extremely grateful that we could avoid a major surgery. And even in India, I think if you see a girl who is absolutely struggling to manage her periods, this is a very decent way of making them oligo or amenorrheic. Every gynecologist should think about this before doing a hysterectomy.
Thank you, Dr. Sai Lakshmi, for this insight. Thank you so much. Now we'll move on to the next topic, and that is Dr. Basab is busy in a surgery. He'll be joining in 10 minutes. So we have none other than Dr. Parikshit Tank. Can we have, Dr. Basab, sir, you are ready?
Yeah, I'm ready. It's okay.
Oh, so sorry, Parikshit, sir.
Okay, I'll come back later. I mean, yes. I'll go after Basab.
Yes. No so I like to invite and introduce Dr. Basab Mukherjee, sir, who is a Vice President of FOXI, and now he's a Vice President of Bengal OBGY Society. He's a figure coordinator of South Asia Safe Abortion Committee, Founder Secretary of ISOBAB Kolkata Chapter, Founder Secretary of IIG Kolkata Chapter, Secretary IRC India East, member of ICOG Governing Council of 2015 to 2020, Organizing Secretary of AICOG 2023, we are looking for that, and Young Gynecologist Awardee of AOFOG 2011 at Taipei. Contributed more than 30 chapters in the book. Welcome, Dr. Basab Mukherjee. He's going to talk on AUB in adolescent. Welcome, sir.
Thank you, Kalyan. First, congratulations to you, all of you. Rakhi, yourself and Niharika for bringing this program into reality. Endolit was Rakhi's plan, and thanks for joining in this committee, in this coordination for the program. I first again apologize that I totally crossed my mind that you told me, Kalyan, that we are there. I was in the group, of course, faculty, but I thought you had added me as just because I was the VP. I just forgot that I have to be faculty, but I've just got something stitched up. I'll share over the next 10 to 12 minutes. AUB in adolescence. Yeah. So, when we talk about AUB in adolescence, I'll just go through a couple of cases. I think that would be most appropriate rather than getting into the theory. The classification that, of course, when we talk about AUB has to be palm coin and nothing else. And I think it's very clear now that whenever you have a case of abnormal uterine bleeding, you need to really classify it into AUB O, AUB A, AUB L, and no longer about menorrhagia and the other terminology which we used to use in the past. So I think that makes it very clear. If it's a leiomyoma, it will be appropriate to stage it and to classify it according to the different positions of leiomyoma separately. So in a case of when it's an adolescent AUB, or when it's in the teenager, you generally would be thinking of AUBO, which would be the first thing which you keep in mind because of the immature hypothalamo-pituitary axis. So a lot of thing would be AUBO, little bit maybe AUBC, where you think about a coagulopathy. Iatrogenic, possible, that could be at any age, so this is no different. Endometrial, less likely, but possible. And the other things are rare in an adolescent or in a teenager when you're looking at them. So here's a 13-year-old girl, which if she presents with heavy continuous bleeding for 2 weeks, how would you try to manage her? So let's assume she's got her menarche at the age of 10, and what are the specific points in history would we elicit in such a case? So when you're talking about eliciting points in history, you're obviously talking about what diagnosis you have in mind. And generally, before anything, we would like to know when the menarche was. So that's the first 1.5 years after menarche. Usually you keep that, you say that period, you'd have some time for the hypothalamo-pituitary ovarian axis to settle down. And then you usually classify the AUB and the polycystic ovary and all the things after that. So features of anemia would be there. Trauma or abuse is something which you must always keep in mind at a teenage level or at any level of a woman. And prolonged bleeding from cuts, hematomas, medication, family history, it could be a lot of things. So specific investigations to arrange at a diagnosis, I think it's important for a few things. One is if your woman presents with acute AUB, in this case, the first priority obviously would be to control the bleeding. Of course, to find out whether she's hemodynamically stable or not, which would be the first thing, whether you need to admit her or whether you need to bring her into the hospital. So most of the cases which we see in a clinical setting would not be cases which you would admit. But at the same time, there may be cases of anemia. Now with the mask, you can't see the tongue, but you can see the conjunctiva, you can see the nails, and you can really find out about clinically how anemic she is. Of course, you need to do a CBC and a ferritin, not more hemoglobin, it's more of a CBC. Hematological anomalies are always in the thought when you're looking at a young girl, and so those things have to be done at some stage, an APTT, PT, and platelets to start with, and then an imaging of the lower of the internal genitalia. You have an ultrasound lower abdomen or a whole abdomen generally to see things which you can see. Endocrine anomalies are very much in the prominence. We will be keeping PCO in the mind because that would be one of the commonest things causing irregular bleeding at that age, besides the immature hypothalamic-pituitary axis. So any PCO causing irregular bleeding, we know that if the bleeding is irregular, it is also likely to be prolonged in certain cases where whenever it comes because of the instability of the endometrium. Thyroid function test or TSH prolactin is a standard format of doing irrespective of gestational age. Any AUB in any reproductive age woman, generally we have a thyroid and a thyroid test done. Urine for pregnancy, some people would put this higher up in the list. Again, depending on the situation, depending on the age, and depending on the history which you elicit. Even if you don't elicit history, a lot of people would do a urine for pregnancy test just to rule out things. So the differential diagnosis for bleeding and this, yes, puberty menorrhagia, of course, is something, again, this doesn't have any meaning. It's nice to say it when you're putting up a lecture of puberty. In puberty, if you put up a symposium, puberty menorrhagia sounds nice in that symposium. But again, as we said, once now it's AUB, it carries less weight. You need to put it as AUBO or AUBE. So something that has to be sorted out. Bleeding disorders in that classical history, which we know about some easy bruising, about dental bleeding when she's brushing teeth, and something in the childhood is something which is standard, which you need to elicit before you move ahead, especially in a case of bleeding in a teenage girl. Thyroid dysfunction, difficult to elicit, but some clinical features may be there. And then is the very difficult idea of trauma, abuse, and that is pregnancy and pregnancy-related bleeding. And that is something which has to be very tactfully elicited through the history, through her actions, through her behavior, the person who's come with us. And generally, senior doctors may have a clue or may have some sort of an idea about how to deal with this once they see that. Sometimes you may not have an idea to deal with it. In that case, you should refer appropriately and do the needful, what needs to be done. So broad principles to be managed in this case, as we see, again, in an acute setting, the first thing would obviously be to arrest bleeding. Replace losses means you don't always need to put an IV line and transfuse. Of course, you can, if you can arrest bleeding relatively fast with hormonal medication, which would be the standard practice, plus minus tranexamic acid, then you could have some time to build up hemoglobin. It could be done with oral medications, not necessarily always IV or injections, but yes, the injectable iron is one of the options which is there. It's more sure, but again, it takes the same time to build up hemoglobin than with oral iron. So then try to identify a cause and treat it, because you're arresting the bleeding, you're giving high doses of progestogens possibly for a short duration of time. What happens after that? So I think once we get a sort of a diagnosis, or once we get an idea of what's happening, then you can put her on something for a regular basis for a few months, because you don't need to give it for a very long term, but sometimes in 3 to 6 months, the problems settle and then it gets corrected on its own. But that's something which we need to assess and treat, and have a close eye on the hemoglobin, how much it's rising, because that's something which you want to know. So looking at another case scenario, this again we picked up from Ashwath's series of Hello Tomorrow, which we had last year, a year before last, of course. 14-year-old girl presents with excessive menstrual bleeding for 8 days. Bleeding was heavy for the first 4 days. She changed 6 pads and then reduced in amount for the next 4 days. Attended menarche a year ago, and her cycles have been irregular since. So this is something, again, not uncommon. Hemoglobin is 10.1, and how do we manage her and what do we do? So this is, so what are the probable causes? Again, as we said, the probable causes could be around anovulatory causes, and assess the severity of the bleeding would be clinically and by lab, and how to evaluate her and how to manage her would be the questions. So anovulatory uterine bleeding seems to be the most common cause. And as we already discussed, immaturity of the HPO axis is one of the common causes, especially in the first 1 to 2 years of attaining menarche, and even in the last 1 to 2 years before attaining menopause. And so other things which could be in mind as systemic illnesses, neoplasms, medication, sudden weight changes, could be loss or gain, and intense exercises, which all are there. So how do you assess the severity of bleeding? From history, you get some idea. Of course, we know that classically, when we go for these public awareness programs at different levels, schools, colleges, Rotary, we talk to them about the duration of bleeding being 2 to 7 days on an average. Less than that is not abnormal generally, but longer than that can result in anemic tendency, and that needs correction, and that needs some sort of a medication and treatment. So mild, moderate, severe could be different ways of assessing the severity of bleeding. But again, this is just a clinical overview. At the same time, there's nothing specific to it. And at the same time, you need to correct the hemoglobin anyway and correct the cause. So how will you evaluate this girl? Again, if, as I said in the beginning, if she's hemodynamically unstable, the entire thing shifts. That, of course, when you look at her, she's flushed, she's sweating, she's got tachycardia, she's very distressed. Then, of course, you need to get her admitted, administer some IV fluids, if possible, need some blood transfusion and or pack cell transfusion, and then to stabilize her. So that's one thing, and to, of course, at the same time, give her IV medication to control the bleeding. And if she is hemodynamically stable, of course, most of the times, 90 to 95% of patients we see would be of this category, where we will be giving some oral medication to stop the bleeding, to correct the hemoglobin, and then to evaluate her for what the problem is. Again, as we said, already mentioned in the previous case, the urine for pregnancy test would be a standard thing, which at all points of time, we have to keep in mind. Some people do it earlier, some people do it late, but I think most of the people now do it irrespective of the history that they can elicit. Pelvic examination, this is a tricky part in an unmarried girl, tricky part in an adolescent girl, always not necessary unless you really are thinking of what you are actually achieving by it in a case of bleeding. Of course, if there's some sort of a tear, which is after intercourse or after menstrual thing, that will be, that again, you should be able to elicit the history, but again, that will be there visibly on external examination. You don't even need to put a finger inside her vagina for that. Generally, you will see it come there, but at the same time, sometimes you may need a speculum examination, which again, under anesthesia would be, if at all, depending on the situation we are. A PR examination is another alternative, which people would like to get some idea about the uterus. Pelvic sonography will give some ideas about other gynecological problems, which are not very common at that age. But of course, from time to time, we do see things. Relevant findings on pelvic ultrasonography, as we said, these are the situations which you may be there, different congenital anomalies and leiomyomas, ovarian masses, but PCO would be the commonest. And most of the times your ultrasound would be not very informative on this sort of a situation if it's abnormal uterine bleeding. So as we said, so this would be the same. The thyroid examination is standard. STI is something which we need to keep in mind, especially when there's a talk of intercourse, and of course contraception in the long term to make sure that she doesn't become pregnant if she doesn't want to. Other diagnostic laboratory evaluation, FSH, well, again, this is questionable. It may not give you much of idea about it, but may not change your management on what you get. Polycystic ovary, if you have, then whether you want to do the hormone screening with testosterone, DHES is something which you won't like to look at. The goals of management of anovulatory uterine bleeding, as we have stressed again throughout this presentation, is you need to maintain the hemodynamic stability, correct acute chronic amenorrhea, return to a pattern of normal menstrual cycles, which may take a few months, but at the same time, that is the idea, to give her some sort of a correction in the beginning and then take it from there. Prevention of recurrence, yes, she'll always be afraid that she may have the same acute situation where she suddenly is helpless and it can happen in the middle of the night, and how to exactly tackle that. You need to give her some tips and some suggestions and some helplines and some guidance on that regard. Prevention of long-term sequences of anovulation, well, that's too early for a lady who's come to you first, and that discussion possibly will be reserved for a future consultation. But at the same time, that's something which we do keep in mind. If it's a polycystic ovary case, then that discussion will definitely come up at some point of time. So moderate can be managed in the outpatient. What medicines would we give her? I think classically most of us would use a progesterone-only regimen, and most of us would use norethindrone or norethindrone as the first line of treatment. 5 milligrams twice daily, 3 times, or twice daily 4 times would be at least standard for initially for the first week, usually tapering, and that would be after the thing is checked. Most of the times this will do. Oral microaspiration is not our first choice generally, but for an acute setting, it generally would be a high dose of a progestogen with gradually decreasing it. And whether you want to give OC pills after that, generally a lot of people may follow it up with OC pills, especially in a case where she is sexually active. But again, not always, but that is something, again, OC pills to stop the bleeding, yes, can be done, but not that effective in an acute setting, more better for a chronic setting. I think that's all. Tranexamic acid all the time. I think tranexamic acid would generally be an addition along with hormonal medication. Usually we try to overtreat in most of the settings. So tranexamic acid would definitely be on along with the hormonal medication, not separately, possibly together in an acute setting. In an acute setting, again, tranexamic acid, you would be possibly giving the maximum dose of 500 milligrams twice daily for 3 times. Three times daily, 2 tablets 3 times daily, which would be the maximum dose. At the same time, keep in mind for the coagulation problems. Thank you very much. I'm sorry for joining late, and I'm sorry for this is the best I could wind up in 5 minutes. Thank you, Rakhi. Thank you, Kalyan.
Thank you, Kalyan.
So you are on time, don't worry.
You were on time.
Any questions, Dr. Rakhi, for sir?
No, there are no questions at the moment.
Okay, thank you, Dr. Basav sir, for such a wonderful talk. You have covered all aspects of adolescent AUB. Now we invite our next speaker, Dr. Parikshit Tang. Dr. Parikshit is right now treasurer of FOXI, and he's a consultant obstetrician and gynecologist at Ashwini Maternity and Surgical Hospital, Jupiter Hospital, Mumbai. He has 80+ peer-reviewed publication in international, national and index journal textbook and CME publication, and has authored 4 books, worked with numerous national and international bodies in aspects of safe motherhood. He's a gold medalist throughout in his career. And I like to say one word for Dr. Parikshit, who has been a guiding force for me in my own life. Fear, he has taught me one thing: fear has 2 meanings. Forget everything and run, and face everything and rise. The choice is yours. And I invite Dr. Parishittam for his talk on
Thank you. Thank you, Kalyan. Thank you so much for those kind words. And I must thank you for making me a part of this program. Thank you, Rakhi. Always a pleasure to participate in programs that both of you have organized. I hope my screen is visible now.
You are visible and audible.
Thank you. So I'm supposed to speak about suppression of menstruation. And believe me, this idea is as old as the stones. If we go back in medical history, right to the Hippocratic corpus on the diseases of women, it had been thought that menstrual dysfunction is a cause for disease. Not all diseases, but a woman not at ease with herself. Pain and infertility are possible in those circumstances, and pregnancy is a possible cure. So you can understand that there was some thought given to the manipulation of the menstrual cycle. And Hippocrates thought that bull's urine or ground up goat's testicles would be instrumental in relieving these kind of sufferings. So there was obviously some inkling that these substances contain elements which would help in regulating the menstrual cycle, so on and so forth. And that's what this topic really is all about. And we've grown up through our professional lives looking at this diagram of the ovarian cycle and how it affects the endocrinology and consequently the menstrual cycle. So when we talk about suppression of menstruation, actually we are talking about two different events, so to say. One is the suppression of the ovarian function, and the second is suppression of the endometrial function. And as you can see from this Venn diagram, there's going to be some degree of overlap when we are doing this. There will be some methods which are going to suppress ovarian as well as endometrial function, but more ovarian. There are some methods which are going to suppress endometrial as well as ovarian function, but predominantly endometrial. So the question, of course, remains that why should we suppress menstruation in the first place? So ovulation suppression is desirable in certain gynecological conditions such as endometriosis, premenstrual dysphoric disorders or PMS, for contraception, and in certain assisted reproduction cycles. Whereas suppression of the endometrial function is adequate if you're looking at heavy menstrual bleeding, as Dr. Sai just gave a very elaborate talk about one of the methods, that is LNG. And you might want to suppress endometrial function for social reasons, for the reasons which Dr. Jam Kannan is going to speak about shortly. Those are a whole different group altogether. So how do you suppress ovulation? Well, there are certain agents which do this, but on an inconsistent basis. So that would be mifepristone. If it has been given in the pre-ovulatory or the follicular phase, then yes, mifepristone can suppress ovulation, and the whole range of different progesterones, which are systemically administered, which could be progesterone only pills, it could be Dynogest, Gestanon, DMPA. All of these have the potential to suppress ovulation, but not consistently. Then there are agents which are much more consistent, almost entirely certain that you'll suppress ovulation if you use them, and they are temporary. So you could have oral contraceptive pills and GnRH analogs in this bracket. And then you have, of course, permanent solutions to suppress ovulation, that is a bilateral oophorectomy or any surgical procedure or radiation to the hypothalamus or and pituitary, which will destroy the HPO axis for the long term. Of course, the permanent methods are not something that are commonly used in clinical practice. How does one suppress endometrial function? Well, you could do it temporarily by all the methods which suppress ovulation. So for example, if you use combined oral contraceptive pills, you're not only going to suppress ovulation, you're going to have an endometrial effect as well. And you have the LNG-IUS, which is probably the premier method of suppressing endometrial function. You could do it permanently, either by removing the uterus or by removing large patches of the endometrial cavity by a TCRE or by endometrial ablation by the first, second, third generation methods. Now, these are nearly complete and nearly permanent. I mean, I wouldn't say that they are absolutes, but you're almost there with these kind of approaches. Now, let's look at some clinical applications. And since HMB has been talked about in great detail, maybe I'll focus on endometriosis first. And then I'll just touch upon HMB as one of the other situations where this is used. So endometriosis, as we all know, chronic disease, multiple methods by which it can be treated. For pain, combined pills and progestogens probably represents the first line therapies. As far as endometriosis related pain is concerned, medical treatment or suppression of ovulation is not really very useful if you're looking at infertility as the therapeutic goal for women with endometriosis. So if somebody is presenting with pelvic pain, and if it's acute or very severe and there's a pelvic mass, then you're probably going to operate. But if it's not acute, you suspect endometriosis, you can give them a trial of oral pills for 3 months and continue if that is a satisfactory response. If it's a suboptimal response, you go to a second line agent like GnRH or Dynogest and then see how things proceed from there. So if you look at medical management of endometriosis, you are basically suppressing the menstruation either by creating a state of pseudo pregnancy by progestational agents or pseudo menopause. In the earlier days, this was with danazol, and in modern times with GnRH analogs. And then you have got various disease modifiers also currently available for use. A few words about oral contraceptive pills. The 30 microgram pill is the first choice. It's safe in adolescents, and menstrual pain significantly improves in at least half the population. Continuous use is much better in these circumstances. So we do what is commonly called as tri-packing. That means give 21 into 3, 84 tablets or so altogether. And you can do this for the long term, reduce the number of menstrual cycles that this woman with pelvic pain is facing. And it gives a significant benefit, not only symptomatically, but also in the suppression of endometriosis. Various GnRH analogs are also available, but the ones which are in consideration in this circumstances of endometriosis or pelvic pain are the depot preparations of leuprolide, triptorelin, or goserelin. And these are extremely effective for pelvic pain, which is related to endometriosis. And they can also be used as an empiric diagnostic test for women whom you're not going to do a laparoscopy in. You can use it safely for 3 to 6 months and suppress and reduce the pelvic pain. But of course, we know that pelvic pain may recur depending on the disease activity. Now, what are the concerns? The problems with GnRH analogs are bone loss, menopausal symptoms. It's expensive to use them, and you may get around the bone loss and menopausal symptoms by add-back therapy with estrogen plus minus progesterone or tibolone. And it does not compromise pain relief. So if somebody is only getting pain relief with this and not ready to get operated, then this might be an approach that you might take. Or you could consider second line agents such as Dynogest or other aromatase inhibitors. Dynogest is something which is emerging and is coming forth as something equivalent to GnRH depots. Minimal side effects, just continue with 2 milligrams a day in the long term, and you get great results as far as pain relief is concerned. So all these agents are recommended, they can be used. And what is thought about today is taking into account the overall picture, the side effect profile, which may suit a particular woman in terms of relief from pain. So this is just a quick comparison for the various agents. Significant differences in the costs if you go to look at it. And the ones which are high effective are the GnRH analogs and Dynogest. Number two would be the COCs and the LNGIs. So these are the various ways in which you can suppress ovulation and endometriosis related pain. As we saw, and I mentioned earlier, that suppressing ovulation or menstruation is not a great idea if you're looking as a fertility outcome. So in infertile women, clinicians should not prescribe hormonal treatment for the suppression of ovarian function, and it does not improve fertility. Just get on with whatever you're going to do for this couple. Now, a lot has been already said about heavy menstrual bleeding and the suppression. There's definitely a place for medical therapy because there are lots of remissions, cures. It's reassuring in certain timings, puberty or approaching menopause, where you want to just bide a few months. Medical therapy is invaluable. And these are all the agents which are available. As we saw, LNG-IUS is probably the number one, and it's what is ratified by the ECLIPSE trial as well. And this is a systematic review of literature which was carried out. And the LNG-IUS is probably the most recommended and the most effective measure that one can take. It's more effective than OC pills, luteal phase progestins, and NSAIDs. So having seen these various clinical applications and the basic principles, one has to apply what is needed for that particular woman in that particular circumstance of her gynecological life and use that agent to achieve what we need to get at. So thank you very much once again, Rakhi, Kalyan. Pleasure to be with all of you this evening.
Thank you, sir. It was a pleasure hearing you.
Thank you, Dr. Parikshit sir, for making such a complex topic, such a simple. It's just delight to listen to you whenever you are there. Thank you so much. Over to Dr. Priyankur for next session. Thank you.
Yeah, thank you so much, Dr. Parikshit sir, for that wonderful talk. So we come to the end of this wonderful talk session, and we had this excellent inputs from our esteemed faculties today. We had the journal, we had the clinical experience, and then a couple of talks by Dr. Basab and Dr. Parikshit Tank. So now for the panel discussion, I would like to invite Dr. Rakhi Singh ma'am to invite the moderator and the panelists on the wonderful panel, a little different topic on gynec challenges in girls with disabilities.
I think, Priyankur, you continue with it.
Okay, ma'am. Should I?
Yes, yes, please. Please
Sure.
invite Dr. Jayam, ma'am. It is always a pleasure to hear from her.
Absolutely.
Definitely.
Thank you so much, ma'am. So can I have the series, please? So it's my pleasure now to invite the wonderful panel. So first of all, I would like to invite the moderator. Can I have the series, please, support? I would like to invite Dr. Jayam Kannan, ma'am, who is like a motherly figure for most of us. She has been a past vice president of Foxy.
Nikita,
can I have the CVs, please? She has been the past vice president of Foxy, and she has been the past president of the Trichy OBGYN Society. Ma'am does a wonderful work towards the betterment of girl children, towards the betterment of children, the womanhood in and around the country, and especially in southern part of the country. And she is a little inclined towards the religious aspects as well, and she has been a social worker and is a member and a portfolio holder of many social and religious organizations. So it's a pleasure to have ma'am with us. So I would now like to invite the moderator, the panelists for this session. So first of all, I would like to invite, can I have the next slide, please? Please make it full screen. I'd like to invite Dr. Krishna Kumari ma'am. Ma'am is a national coordinator of Foxy currently. She's a national corresponding editor of Jogi. She was a governing council member of ICOG. and also professor at the Apollo IMSR, Hyderabad. It's a pleasure, ma'am, that you have joined us. Thank you so much.
Thank you.
Our next panelist today evening is Dr. Parag Biniwale, sir. He's a senior consultant.
Dr. Parag has sent apologies. He's a little busy, I believe.
Okay,
He will
sure.
not be able to be there.
Sure. So he is currently the vice chairperson of the ICOG, and so he'll not be able to join us today. Next with us, we have Dr. Reena Wani, ma'am, who's a professor and unit head at the HBT Medical College and R.N. Cooper Hospital in Mumbai. She was the president of the Mumbai Breastfeeding Promotion Committee and also the chairperson of the Foxy Perinatology Committee. Welcome, Reena, ma'am. Next with us, we have Dr. Achla Batra, ma'am. She is the professor at the Department of OBGYN, BMMC, Safdarjung Hospital, New Delhi. Ma'am is currently the president of the AOGD and was the president of the Narchi Delhi chapter. It's a pleasure, ma'am, you have joined us. Thank you so much for being here. Next with us, we have Dr. Usha Goenka, ma'am. Ma'am also will not be able to join us. She is stuck in emergency duty. So can I have the next panelist, please? Yeah, we have Dr. Meena Samant, ma'am, with us. She's a senior consultant and HOD at the Kurji Holy Family Hospital in Patna. She's a chairperson of the Foxy Clinical Research Committee and also the Secretary General of ISOPAB. Welcome, ma'am. And next with us, we have Dr. Arun Madhav Barua, sir, who is currently the chairperson of the Northeast ISAR and also the president of the IMS Sipsagar branch. Sir has been the chairperson of the Food, Drug, Medico Surgical Equipment Committee and also the organizing secretary of AICOG in 2010. Welcome, sir. So I now hand over this platform to our panel moderator, Dr. Jayam Kannan, ma'am, to take us through this wonderful next 45 minutes to 50 minutes.
Thank you very much, Rekha, Kalyan Bamade, and dear Priyankur, for giving me this topic, though not a very happy topic, but you really made me read more and learn more. I really thank you and greet you also. Greet you for Deepavali also. And my other colleagues who are going to be here with me are no less people who can individually do a panel. So when I went into the WHO work, I saw it is an umbrella with not only impairments, activity limitation, and also if there is official participation restrictions. We all know about the double discrimination, gender-based violence. Am I not audible?
Audible.
Yeah.
You're audible, ma'am.
Yeah, all these things. Now, I look on to Dr. Reena Wani, the high topic of couple of weeks discussion, LGBTQ girls are also disabled girls, as it has been told by Frontiers in Reproduction 2020. May I request Reena to give her opinion on this and take this discussion further. Reena?
Yes, thank you, Jayam. Ma'am, this is such a touchy topic that when we say that, when we use the word disabled, in fact, we have to be politically correct. And in fact, now we no longer call somebody as short. We say she is vertically challenged. Similarly, when you have the choice of writing your gender, now there are three options. It is male, female, and rather not say. Similarly, for your choice of your sexual orientation, to put the label that LGBTQ girls are disabled, we are being very judgmental. I think this is something we have to change our own mindset. And we have to consider them that this is part of the mainstream, of this current mainstream, and we have to accept them. And in fact, when homosexuality was legalized in our country, there was rejoicing and rainbow parades and things which have been there across the world since many years. And for this, we have to open our minds as gynecologists and say that the LGBTQ girls also are part of our regular population. No, my friends, they are not disabled. I think that's the way.
Okay, so this is not to be taken as a disabled person. Now I go to one more question to you, Reena. female genital mutilated girls, are they disabled girls?
This is a sad story of iatrogenic disability, because this is an age-old cultural thought that female sexuality or pleasure during intercourse should not be there for women. And in certain communities, even now, I'm very sad to say, even in a so-called liberated country like America, there was a scandal of a whole series of girls of a particular community who were found to undergo something known as khatna, which is the genital mutilation. And our FOXY policy statement on violence against women, which was in 2013 put up by our president, Dr. Durusha, with Dr. Ashwini Balirao Gandhi, who was then Adolescent Health Committee chairperson, has been reinforced in 2019-2020 with our own dear president, Dr. Shanta Kumari, in which we have put up the fact that female genital mutilation is also a crime against women, and we as Foxians take a stand that this should not be done. So I think we have to look at this as an iatrogenic disability which has been enforced on these poor girls due to social and religious conditions.
Thank you very much, Reena. Please stay back. We have some more interesting questions also following up after I address to each person individually. Over to Madam Krishna Kumari. Thankful to you for sending your slides also. I have taken a couple of slides from yours. Basic screening and pelvic examination. Please enlighten with your views.
Very good evening, Madam, and I thank you. I thank all the chairpersons for inviting me. I would like to congratulate Priyankur for becoming the Vice President of VATAG. Congratulations to Dr. Priyankur. Hard work always pays off. Thank you so much, Jaya Madam. It's always a pleasure being a part of, being with you. So coming to the examination part of point of view, actually, as far as the disabilities are concerned, it starts off much before the patient comes to us. So there is a problem even not only with the provider that is with us, but also with the patient. From the time they access the hospital, most of the times their access to the hospital is itself very difficult. So it has to be addressed from there, how they can easily access. And we are very well know in our country, we are not tuned, our systems or whatever public places or hospitals, they're not tuned for these disabled men or women. So it's very important that it is taken up very importantly. And now coming up to the gynec examination per se, we need to understand that the gynec examination needs a lot of special care. The first most important thing is we should have enough time to spend with them, and then a proper training of not only the person who's examining the doctor, but also the whole staff. They should be geared up in all ways, whether it is by physically or mentally, or as well as by the infrastructure. They should be tuned for that. And for that, they should have their infrastructure like wheelchairs and the tables, which can be adjusted to the level of the wheelchair. And then also they should have the special stirrups. And for example, and an assistant should always be there who can help them to keep the patient in the proper position. And the position of the patient also should change according to the requirement, but whichever examination positions we take, whether it's knee chest or lying or heel to heel positions. And when there are padded boots, in addition, they have an advantage of not having the need of an assistant. And we also have to recognize that it's not only the examination, the even basic screening is very much compromised in these patients, as we can see from the amount of screening for cancer, cervix and breast, but including simple things like self-breast examination or a clinical breast examination by the consultants. And of course, the colposcope, they should be specially mounted. And in this spinal cord patients, they have a special problem of autonomic dysreflexia. So if you touch them, they immediately have a bowel or bladder movement. So they should be emptied, and you should see that there is enough xylocaine applied prior to that. And of course, they can also go into sudden shooting up of hypertension. So all this should be taken into consideration when you are examining these patients.
Thank you very much, Krishna Kumari. Now I move on to my great friend Arun Madhar. Please come out with your challenges on breast screening and the higher chances of early cancers in disabled.
Thank you, ma'am, and thanks to everyone, including Kalyan, because this has been again a great academic session that we have been really learning a lot, and rebrushing our old thoughts and new ideas has been always incorporated when we come in. And this sort of particular presentations, which really touches every gynecologist, not to say the gynecologist, probably every man. When you see anyone who is disabled, I always say to my family members that we must consider ourselves to be lucky, because we'll never feel until unless we put ourselves into their shoes and how they feel like into their day-to-day activities. Having said so, the question that has been put specific to me regarding the breast issues, we remember that these disabled girls, or whether they are challenged girls or in whatever way they are, they also get a feeling that they are not in a normal way of life. So that itself put them on an additional distress. So what I would like to suggest is, during my tenure as a practicing gynecologist for 36 plus years, we have seen a lot of patients of similar nature who really have been submissive through their parents. They do not want to disclose anything to them, and having them in an examined in a suitable environment is a challenge itself, because as it has been told that they need special areas, they need special preferences, and they need special attitude from both the care provider and the whole healthcare facility needs to be upgraded to convince them. Normally, when we say that breast self-examination is a way forward for a standard girl or a standard woman, they themselves remain challenged to whether they'll be able to do this on a regular basis. So the onus again is on the care and the deformity or disability that particular girl or the woman is suffering from. If we can really put them with a little amount of photographic representation, which today is really available for a normal people through Google Images or even in YouTube search, but we have to make them feel that they can always do that, and at least enlighten them, show them the way that they can be a part of the normal life as well. Because the risk and consequences of the woman in general are always existing for these girls too. We should not be convinced that since they are disabled, since they have a lot of other deformities, they are protected from other screening procedures. So heavy menstrual bleeding, cancer screening are all a part of this particular. So we have to really plan out how to go ahead and give them the appropriate advice and guidance to make themselves protected from the illnesses.
Thank you. Now I move on to the exact problems which starts with menarche. Menarche is supposed to be not disturbed in spina bifida and other things. In brain injuries and spinal cord injuries, it is supposed to be either delayed or precocious. In rheumatoid arthritis, they are supposed to have later onset of menarche and increased rate of ovulatory dysfunction. Over to Achla Batra, your views on the pattern of menarche and the words which have been expressed by me as a just a crisp.
Thank you, Dr. Jayam. I think a very nicely chosen topic, well talked about. See, menarcheal pattern, I wouldn't say disabled, I'll say differently abled girls, depends upon what is the disability or they have. It may be a physical disability, motor, visual or auditory. While motor disability may not affect menarche pattern. But because these girls with motor disabilities, they are, they tend to put on weight. And when they are obese, they can be, disturbed menarche. In visual disability, it has been seen that menarche occurs earlier. While the menarche pattern the age may be same, but, with menarche, especially girls with Downs or autism, when menarche occurs, what happens is their behavior pattern, they become little worse, especially girls with autism, they become little more violent at that time and more withdrawn at that time. In Downs, the puberty is delayed, and when there is injury to the brain or spinal cord, there may be a normal menarcheal pattern, but sometimes there is, because of the area injured, they may have a precocious puberty, or they may have a delayed because of hyperprolactinemia. And then, not only that, because they are disabled, disability is not only physical or, the neurodevelopment. Even a girl who has juvenile diabetes, a girl who has epilepsy since childhood, they also get a disability certificate and they are also disabled, because with epilepsy per se may not affect menarcheal pattern, but the drugs they take, that can affect their
Okay, thank you very much, madam. Now, of course, the dysmenorrhea and other things have been already discussed very clearly. As this in Parag is not there, I am leaving his topic. And now I come to how do paralyzed people deal with periods? May I have Dr. Meena Samant? Meena is not there?
Is there, ma'am? Dr. Meena is
Yeah, I'm there, ma'am.
Yeah. Any idea about, apart from the drugs whichever have been used, about the tampons and the newer one, this is the Kila cups?
Yeah, the cups are becoming more thing, but as in hospital, even the diaper use is also quite common amongst them, especially when they're in hospital setups and all. Even elderly now, when they have these problems changing and not able to change for themselves, diapers are becoming. But then, yes, for this, the cups, the menstrual cups, as of now, they are becoming more common. Even the younger age group, in normal menarche, normal girls as such, and others also. They don't have to change so often, and they can clean up.
Reena, can you expand on this? This in Kila cups, you have any idea about? Have you used it?
So Jayam, here I would like to say that although that we have had description of these the menstrual cups and the Kila cups, in practice we have found that in our country, at least for the differently abled girls, they are still using sometimes the cloth or that along with diaper. Very few are able to use these specific items which are described in Western literature. But in practice, we are not finding, and as Kalyan mentioned at the beginning of the program, the tragedy is still that the most commonly used method to deal with periods is that the parents come and ask for a hysterectomy.
Yes. That I am coming with the Ashley's treatment. That is, we are going to debate it. But I thought we should make this because everybody people have talked about all the drugs and other things. Menstrual hygiene becomes very, very important. I have one more slide at the end about the menstrual hygiene. I thought we can just give an idea to the gynecologist. Probably supposing somebody who is in the higher socioeconomic strata comes to them, they can offer this because they seem to have some advantages, as you at Mumbai and Achla madam at Delhi probably might have had a chance to use it. That is what I thought. That is why I brought this out. Okay.
Can I pinch in, Dr. Jayam ma'am? Can I pinch in? This cups are being used by many of the teenagers and the young adults, but very fondly they have been using it. But the only thing is for differently abled, it would be little difficult for them to be using it. But whereas in youngsters, it's becoming more common nowadays.
Yes, yes. Only thing is probably for a person who is disabled, unless somebody supports them, they may not be able to use it very clearly. Yes. Now coming to this big question of this Ashley treatment. Can we have now or at the end? Can we go at the end? We'll have all of you, please think over it, what you are going to, because I have seen this Ashley treatment right from 1992 when it became a big topic in the All India Democratic Women's Association. Okay, now moving on to this. Nothing prevents a disabled person from being infertile also. Yes. I feel that they should be given the same amount of care and the husband also should be asked to respond. So I request Meena to come out with your ideas.
Yeah, that depends on what the disability is. And any person with any way they are differently able, whatever we can say about that. So it depends. They do have their family needs. They may be desirous of having a child, and we have to respect that. And supposing there is mental, retardation, to see that they are able to look after the child, who would be looking after that, and how far they can go to that, what is the support system should also be looked at. Then coming to, of course, the disability as such. So yes, they can have, some of the disabilities are, can also lead to infertility. And then because they may have sexual dysfunctions because of that, then of course their fertility as such, because we know there are so many other congenital conditions that may, impair fertility. And then of course, when we work out the fertility issue, we have to do it in the same manner as we we would be doing for any other infertile couple. Both the male and the female partner has to be investigated in the same way. And then, of course, they do have a right to have offspring.
I still remember a couple who are both IQ-wise 74, but they are otherwise all right, 74, 75 IQ. The mother brought the girl and the husband. They didn't know what is sex. But the minute they were put across to a sex specialist and he was taught how to have a sex, then the next cycle she conceived. But it so became a problem that during pregnancy he demanded sex with her every day, which the girl could not cope up. So we had to take the girl out of his sight and did the delivery. 4 months later, when the girl came to me for a regular checkup, I found her 3 months pregnant. So what we did after the second delivery, nicely did a sterilization for her. So probably if these people, because they don't have any other option, they are into that sexual life very much. And infertility as such may be considered as a rarity, but it is, the beginning is rare. But after that, asking for more children is a common thing with these people. Now, coming to contraception, which is a big thing which has been discussed by everybody. And we have looked at all these things. In spite of all these problems, we have talked about implant, context, everything. Now, since Usha Goenka madam has also parted out, I request Krishna Kumari madam to take up this question of contraception and enlighten us with your ideas. As many people have talked about progestin only pills, and they have talked about the depometroxyprogesterone and all its complications. But what your idea is about this ring, IUDs, and condoms and others?
Yes, madam. Before I take up this question, just Shanta wants to say, wants to say hello to all of you all.
Hi, madam. Jai madam, Rakhi, and everyone.
Thank you, Shanta. Love to see you here.
Thank you, madam.
Thank you. Thank you.
Thank you for joining in, ma'am. Shanta.
Thank you.
It's a real pleasure to see you and meet you.
I think we should congratulate her personally now, since she's with us for all the things
Yes, yes, yes. A bigger congratulations.
Thank you all.
Thank you, Shanta. It's all your work here. Come here. Thank you.
Bye.
Bye. So, Krishna Kumari is leading on with the contraception that she, with all her years of practice, decades of practice, will put upon. Will you just take this one or go in for the other things of Ashley treatment? That is what said hysterectomy in these things, or making this girl not grow up at all with removal of the breast buds, removal of the uterus, and given early estrogen therapy at the age of 8 and 9. So the girl is small, the parents can carry it, the girl doesn't become very tall or anything. This has been done by a professor, a couple professor in 2002 at New York, and it was a big topic of discussion. So after that, there were people who were for it, there were people who were against it. Even in India, we know that in Pune, we had a big problem when there was a camp for hysterectomy for mentally retarded people. So I would like you to give your opinion on this and on that.
Yeah. I mean, coming to contraception, actually, the problem with these differently abled, I mean, there are very many types of disabilities. It could be physical or many other types, whether it's mental or whether it's sensory. So as far as if we are separating the sensory, that is the visual and the auditory loss, what we have with us, if you're talking about physically disabled people, we have to, the most important thing we have to remember is that their mobility is very much restricted. So as such, we are very much worried about anything which increases the, I mean, when the mobility is restricted, we are worried about the DVT. So when we are looking at DVT as a perspective in this women, I think that's the reason why people have opted for rather than COCs, other methods of contraception. And when you're looking at even progesterone alone, it is very important that the different types of progesterone have a different risk of VTE. So we have to choose maybe probably the least one. That is why they have chosen the levonorgestrel, which is relatively having lesser risk of VT when compared to the other types of progesterones. Then, of course, condoms and IUCDs would be quite fine. And we have seen that there have been patients who came even for, I mean, mothers who brought their daughters for having a LNG IUS inserted, and so that the bleeding comes down to the minimum, and also they have an advantage of contraception. Two things, because two major things that worry a mother when they bring their disabled child to us. One is about menstruation, the second is fear of being abused and having a pregnancy. So we can address both of them. Their option for that is hysterectomy. And I think we as obstetricians are not, I mean, as gynecologists and obstetricians, we are not at all in favor of doing unwanted hysterectomy. So if we find an option where we can serve any method which can serve both the purposes, that it decreases the amount of menstrual bleed as well as prevents a girl from being at least having a pregnancy. Abuse is not what we can monitor 24/7, but at least she can be protected from having a pregnancy. So maybe having such a system in place would definitely, I think LNGU IUS has a role in these girls. I think that is my personal opinion. As far as all other methods are temporary methods, can, I mean, like condoms or one-time usage methods are not advisable for them, because they are probably, if it is a sensory or visual or auditory disability, yes, they can be advised regarding any method. So they have an option of any method.
In this question, we will take everybody's view. Over to Achla, madam, your view on Ashley.
I'm totally against the Ashley treatment, and I think we are trying to save the uterus even at an older age now. And these young girls, why should we remove their uterus just because they are menstruating? If their IQ is little better, yeah, if their IQ is little better, they can definitely be taught to look after their menstruation.
Meena?
Yeah,
So,
there are. Okay.
sorry. Yeah, Meena, go ahead. Yeah.
Okay, I mean, removing a uterus, it also involves surgery. It is also a kind of mutilation, and there are ways apart from surgery which can be done to, give a better life as well. We have those. Her, even if she attains menarche, the bleeding can be suppressed. We heard of so many ways being discussed just now. So anything could be used. She need not actually go. And also the fact that suppressing the growth, and also there are other implications. Surgery itself, like I said, was this. And we really do not know in due course how she would respond to it. And we've assumed, okay, this was one case who was severely disabled mentally, but taking it as a standard for other girls may not, really apply to that kind of.
So non-therapeutic hysterectomy is not accepted by all of you. Reena and then Raki. Yeah, Reena.
Here I would like to point out that I myself am a student of KEM Hospital, which is supposed to be the Harvard for our medical education in Mumbai. And there was a case series of mentally retarded girls who underwent hysterectomy years back when I was
in 1990s.
Yes,
Before
and
2000.
which was published. Now things have changed, but I have to admit I myself have done 2 hysterectomies for mentally retarded girls. But there have been certain extenuating circumstances. One was where she had also come with prolapse, but the difference as compared to 30 years back, and the other one was where she was certified by the psychiatrist as being severely mentally retarded, having failed other medical treatments. We actually had to take the dean's permission, administrative permission, written undertaking from the home where she was staying. In fact, one of them did not even have parents. She was staying in a St. Catherine's home. So all that was done. So it is not as simple, and it is one of the last resorts. And definitely we do not look at it, but if it is to be done, it has to be done within the purview of the law, and we have to be very careful, because now this is something which we can also get into trouble if we take it lightly and go ahead in a very random manner for this. It is no longer acceptable.
Thank you. Order Raki?
Yes, ma'am.
Yeah. What is your opinion on this? Raki doesn't. Yeah. This is such a medical legal problem that it has to have, as Reena said, the institutional ethical permission, the district level ethical permission, and magisterial permission, and a group of doctors to say, yes, this girl definitely requires hysterectomy. And the program is now has to be videographed, so that what are the organs you are removing also have to be shown in the video. That is the latest law which is being put up outside this country. Probably in our country also, if somebody goes for any medical legal, the same thing what is applied outside will come applied. It is not going to be bad. So we should have, normally we don't videograph what we do in the theater, but this is one case in which it has to be videoed and it has to be kept preserved, so that at any time anybody comes and questions, it has to be. Yes. Have I missed anybody else?
Ma'am, I would like to add one point over here, that apart from the surgery, the counseling session, whatever we are doing with the patient also has to be videographed and documented per se. The counseling for doing a surgery also.
Is Arun there?
Yeah. Yes, ma'am.
Arun, your opinion?
Obviously, madam, the era where we are trying to preserve every organ in a body, both man and woman, there cannot be a question of removing the organ for the sake of just the treatment. I think this is totally not acceptable anyway by any gynecologist or anyone who really have a feeling for our own self.
Yeah.
This is a
If you have respect for a soul, we won't do it.
Yeah.
Yeah. As Priyanka said, a religious person. For the soul, I would not advise us when we have other armamentarium, which we have got. So when we look at solutions, I think more than gynecologists, the social people have come out with a lot of answers to this. One of these answers is what has been put up as into 10 years ago, this one, which is being put up as a menstruation kit with all the details. If anyone of you can take it up and give me the details, I'll be happy about it. Anybody has idea about the kahani har mahini ke? So this is one thing which is available. Probably we can show this and make them understand how they have to use be a hygienic during their menstruation. This is one thing which has been said to be used very clearly, especially in blind girls with the use of Braille. They are teaching how to be careful not to get infections, how to be hygienic during menstruation in spite of using the cloth, which Reena Vani has promptly brought it up and made it very clear to all of us. The other one which is there both in India and Nepal is the WaterAid and London School of Hygiene Management has put out very clear details for both blind and deaf women and tactile graphics, how to take care of your menstruation. This is there both at Delhi, India, and also in Nepal, and they have come out with the picturesque description. Probably this may be picturesque, may be useful for the girl who is able to see, and the Braille one will be used for somebody who is not able to be very clear about it. And this Braille is really something which is helpful. This is one other thing, probably, and Achla madam from Delhi should be able to give more details if she has.
No, I also read about it after I was invited to this panel, and that, yeah, that these things are available, and there is how I do it. This kind of booklets are there with very nice pictures are there for the girls to see and understand. Yeah.
So this can be, see, probably as doctors we should give them ideas as how they can go forward to support these girls. Then the other one is, as a digital world has come up, is the Clue app. Probably now even a motor disabled girl should be able to use a cell phone. Somehow or other they use a cell phone. And probably this is one thing American College has come out with a Clue app in which they have given about so many, I think 46 pages are there in this Clue app, which is also helpful for the gynecologists also. Apart from the girls, about the details which they can look into for all their menstrual problems. Probably this is one thing which may also be taken up by all of us. As they say. Any idea about Clue app? Anybody has used?
No.
No idea. Yeah, Clue app. Clue app. Probably we can download it and see that also in. It has got lot of messages in that Clue app. Then the last but not the least, for the gynecologist 10 years ago, how to deal with this disabled woman. Gynecologic and obstetric issues confronting women and disabled, how we have to look at it, has been given by this excellent lecture, and it is available in this number. And probably I would like every one of us to go into it and learn more from it, because we don't get details in the textbook of gynecology on the topic given to me by Rakhi. Disabled girls and gynec challenges. I don't think Williams Gynecology or Novak's textbook of gynecology or any other gynecology book I could get any reference. So this is how I went into reference and added. Probably we can suggest this Clue app and this one which can be noted down for gynecologists to go into detail. So as a final round of questions, for what message you would like to give for the disabled one? Reena may start with a message for the doctors.
Thank you for the three committees who have focused on such a underrepresented area. But what I would really like to say is that here we have to look at the caregiver also. When we are counseling, we have to counsel the caregiver in the proper management. And one word I would like to say, I have had many requests for hysterectomy because they don't want them to get pregnant. There we have to counsel them that by removing the uterus, you are going to make her more prone to sexual abuse because you will not know that she has become pregnant. So we have to protect these young girls by a holistic approach and look at their caregiving circle, and that is our social responsibility as gynecologists.
Thank you. Thank you. Krishna Kumari, madam.
Yeah, thank you so much, madam. Really again, even I congratulate for this wonderful topic that the chairpersons have given us, unusual topic. So I think the approach should be very tactical, and it's very important that we lay down some rules. I think it's high time that we exclusively lay down some guidelines or whatever we can to help these women and train our own staff and doctors properly. So, and also see that what are the infrastructures available and how to make our hospitals, at least every place they should have some hospitals which cater exclusively, so that they have all the equipment, infrastructure, trained staff available. And most important, I think all of us should spend more time with these people and tell them what are the difficulties they're going to face and make them capable of facing whatever their problems are going to be.
And if you are in a heavy practice OP, do not give them tokens. Probably make
I
them
think
sit in the first
specialty.
row.
It should be recognized as a specialty clinic, and it has to be there specifically as a separate. Although we don't want to separate them and brand them as something else, we can like we have menopausal clinic, right? Like we have postnatal clinic. I think we should have some beautiful name and come up with specialty clinics for these underprivileged.
Yeah, okay. Oh, to Arun, any beautiful name available with you as Krishna Kumari wanted?
Special clinic for special people.
We have to really put our minds together to get a very special name, and really thought-provoking that they deserve equal care or even better care, because they are little compromised and we should not let them feel. And I think as a care provider, and as Rina Watri said, the trainers should also be trained to how to deal with this subclass, because this was never attended, and probably we must applaud the committee members for bringing up the issue, and they have made us read a little bit, and probably those who are really eager to read further should read the presentation that is already in front of us and enhance their knowledge and carry this important information to the society that we care for them in a special way.
Achla, madam.
Yeah, I think I would just say that the trainers need to be trained too. Like today, when we came for this panel, we've come to know so many things, and we should be, this kind of thing should be done more, so that more and more people know how to deal with these women, because hysterectomy comes as a very easy option to everyone, because probably they can't think of at that time what is to be done. So I think what needs the training of the gynecologist is also required, and definitely we should have a multi-speciality clinic for them where they can take appointment, and whatever problem they have, whether gynae or other, there should be one place for them, where they can come easily without being in the queue, because still in my hospital, they come in a regular OPD only, standing in queue. Of course, if somebody tells, we see them, but then it is difficult for them. I think we should have a special clinic for them, and we need to teach, we ourselves need to learn more about disabled women and their problems.
Madam, so can I make one statement? I've just seen it in the chat box, somebody saying that, but the numbers are few. there is something known as invisible disability. There are a lot many more. What we see is only the tip of the iceberg. So I think that's our responsibility to bring all the underlying numbers. There's so many types of disabilities. So trying to find them out and having a structured way of approach is very, very important. That's, I just wanted to answer that question.
Thank you. So Meena will be able to take it up in her clinical research.
Maybe we have to look at that.
Yeah.
But what I wanted to say
is defined as disability?
Yeah, that is another thing. Any physical, not only physical, but there are other ways where one is not able to give their full potential because of any defect, physical or otherwise. Even like we know intellectually also. Recently held this Olympics. We know what feats these specially challenged people can do.
Yes.
And only what we have to do is support them. And also to understand they do also have some gynae and even obstetrics, what we can say is problems because of those difficulties. And we as obstetrician gynecologists need to understand that. And in our hospital, the orthopedics run spastic clinics once a week, once a month, and they have physiotherapists and social workers all joining hands together, giving trainings there, all kinds of things. Though we are not actually involved with them, they go home and give them physiotherapies and give them trainings to walk and to interact. So actually when people have those, they know where to go to. And even when we get some patient, then we look up and ring up our colleagues and try to find out what. But today Dr. Rakhi, brought us all together to really think and how when we are faced with such conditions we need to do. And actually our sensitivities have to be high to cater to that kind of infrastructure that we need to provide so they can live as normal a life as possible in our hospital settings. The infrastructure that Dr. Krishna Kumari talked about, I think that is really a good way to go ahead, giving them, because they have special conditions, so we need to be equipped with special services for them.
Thank you very much. I think we as team has done a small justice to the topic, great topic given to us by Rakhi, Kalyan and Niharika. I really feel very happy that he had so many learned, intelligent gynae obstetricians with me who could just like that give the raising ideas so nicely, promptly, softly, and touching the hearts of every obstetrician. Thank you very much for all of you, and over to Rakhi for her program.
Thank you, ma'am.
Thank you, Jayam, ma'am.
Dr. Jayam, for such a wonderful leadership and making us all think. Thank you, Dr. Jayam.
Thank you, thank you.
Thank you, Dr. Jayam. Thank you very much.
Thank you.
Thank you, Dr. Jayam, ma'am, and all the esteemed panelists, Dr. Achla, Dr. Krishna Kumari, Dr. Reena, and Dr. Meena Samant, and Dr. Arun Barua, all of you. It was a really mind-boggling and then thought-provoking panel, which I definitely learned a lot of it today, which I was not that much aware of. And definitely it calls for thought for it that we need to work more on this line and train our gynecologist as a TOT to this aspect of it, that we need to be a little more sensitive and understand the requirements of this. Over to you.
Thank you. Thank you. I will really thank Shanta for her presence in our panel.
Definitely. It was indeed a pleasure to have the President Foxy, the elected treasurer for FIGO, to be there along with us today and barging in, and I was very excited to see her.
When I addressed that question to Krishna Kumari, I did not know Shanta was standing behind, And just like that, I was going addressing round, and lovely she comes there. Such a happy thing. Because
it was icing on the cake, yeah.
Yeah, it was definitely an icing on the cake. Over to you, Kalyan.
Rakhi, let's have a photograph of the panel.
I took, ma'am, I took the photograph.
Okay, nice. Send it to me. Okay. Yeah. Over to Priyankur or Kalyan.
Thank you.
Kalyan, are you there?
I will stop share. Okay.
I think Kalyan is might be busy somewhere. Before I end the whole panel and the workshop for today, the webinar, I would like to formally give the vote of thanks to all my esteemed faculty over here today. Right from, first of all, the faculty who barged in, our very own President Foxy, Dr. Shanta Kumari, for giving us enlightening presence to us. And thereafter, I would like to thank Dr. Ravindra for his talk on the journal article, Dr. Sai Lakshmi, Dr. Basab, who's the Vice President of Foxy for all the 3 committees, and Dr. Parikshit Tang, the Treasurer of Foxy, Dr. Jem Kannan, as always, she's an academic piece to hear too, and she always would make the whole panel completely interactive and with all the newer advances being there, and rightly chosen, and my esteemed panelists, all of them, Dr. Krishna Kumari, Dr. Reena Wani, Dr. Achila ma'am, Dr. Meena Samant, and Dr. Arun Barua. Thank you, all of you. And I cannot end this thing for giving the vote of thanks, without thanking Dr. Priyankur for coordinating the whole thing for all the 3 committees for us. That is Endocrinology Committee, Public Awareness Committee, Dr. Kalyan, and Young Talent Promotion Committee from Dr. Niharika, and the academic partners for the day today, Zydus, the Zydus people. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, one and all. Thank you.
Thank you, ma'am.